afternoon. On behalf of the Brazil Center at LLILAS, it's my pleasure to welcome you today to our talk by Dr. Marcia Castro on the COVID-19 crisis in Brazil. Dr. Castro is the Andalo Professor of Demography and the Chair of the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. She's also the co-director of the Brazil Studies Program at the David Rockefeller Center for Latin American Studies. Dr. Castro's research focuses on the development and the use of multidisciplinary approaches to identify the determinants of infectious disease transmission in different ecological settings that can inform improved or new control policies. She has expertise in geospatial methods, population dynamics, and mortality demographics. Aside from research projects on COVID-19, Dr. Castro's work has focused on dengue, Zika virus, chikungunya, and tuberculosis in child development, as well as climate change in the Brazilian Amazon. And Dr. Castro has agreed to take questions after the talk, so please feel free to post them. And now it's my pleasure to present Dr. Marcia Castro.
Thanks so much, Seth. Thanks for the invitation. I'm really happy to be here. So I'm going to share my screen. So I'm going to talk about COVID in Brazil, and what I would like to do is really to talk a little bit about the challenges and the opportunities, so the context that Brazil had even before COVID came, a little bit about what was the response that we saw at the different levels, so the federal level, state level, and local level. I'll go over some of the outcomes and what they show, and I'll end with some reflections on what is next on this pandemic. So regarding the context, there are three things I really want to emphasize. The first one is this infodemic momentum that we live, and this is not just an issue for Brazil, that's an issue for pretty much every single country, which is this rapid dissemination of disinformation. And what we see is that this is a really critical issue in Brazil. This is connected to the role of social networks. We have many different conspiracy theories circulating, but we also have the government also disseminating misinformation. So it's a big challenge. If we think of the bigger picture, it's also important to remember that we had top journals like the Lancet and the New England Journal of Medicine that had to retract a few articles that had been published because the data and the information could not be validated. So this is a really important issue we have to keep in mind that affects people's perception, people's understand of the situation, and therefore the adherence to control measures. The second point is that doesn't matter which pathogen we're talking about, if it's a virus, if it's a parasite, whatever it is, the pattern of transmission that we see in different localities, it doesn't really depend only on the pathogen, but it does depend on how this pathogen interacts with society. It depends when it was introduced, and it depends on the different variety of characteristics that define that particular area. So on the left, you see a series of epidemiological curves for different countries, and there are not two that are the same. And on the right, we see also epidemiological curves for COVID for each one of the states in Brazil. And again, they are all different. Now, again, the way the pathogen interacts with society, in public health, we have a good framework to describe this, which is the social determinants of health. And the great thing about this framework is that we have characteristics at the individual level, but we also go to the household, to community. We talk about policies. The environment is also included in here. So it's extremely comprehensive, and it's called social because it has to do with society as a whole. So what is also important to keep in mind is that any of those factors that are listed in here are important when we analyze inequalities in a country. And any inequality is illuminated in moments of pandemic. So we're going to go back to that in a minute. So if we consider this context of the social determinants of health, what we can see is that in Brazil, even before COVID arrived, on the economic side, we had a scenario where inequalities were going down, and the top graph on the right shows the Gini coefficient, which is one measure of income inequality in a country. That was very high, and Brazil has a very high level of inequality historically. So anything above 0.5, it's extremely high. But it was coming down, and then with the economic recession in 2015, this trend really shifts, and we have an increase in inequality, and we end up 2018 even higher than 2012. And now, we started talking about maybe the 2010s is going to be another lost decade for Brazil, just like the 80s were. On the bottom, what we see are three curves. Each one is a different way of measuring poverty in a population, but regardless which way you measure, what we see is that by 2018, we end up with a level of poverty that is either the same or even higher than 2012. So what we see is that even before COVID, with the economic recession, we have inequality going up, poverty going up. And what we see is that in 2019, so right the year after in the graph, the top 10% wealthy people in the Brazilian society concentrates 55% of the total income. Another issue related to racial gaps in the population. This is an estimate of the life expectancy at birth in 2017, or the average number of years you would expect a person to live. And here it compares whites, which is the yellow dot, and blacks, which here includes blacks and mixed race, based on the usual racial categories that are asked in the Brazilian census. So what we see is that there's an average of 3 years, a gap difference between the life expectancy of blacks and whites for Brazil. But when we look at the different states, this could be even higher than 7 years. So, and on top of that, there is a huge regional gap as well. So the life expectancy between the different states also vary by about 5 years. And another thing also, again, before COVID came, is if we look at the Human Development Index, which has 3 components: education, income, and longevity. The curve in the middle, so the pink curve, is how the index changed from 2016 to 2017 for Brazil. The 2 curves next to it, the yellow and the green, are the curves for males and females. So the gap between males and females in the development index is not very high, and therefore they're very close to the index for Brazil. But when we break this by racial categories, the index for whites are way above in the curve, so they're much higher, and for the blacks are much lower. So the gap between the Human Development Index among whites and blacks is much higher than the gap by males and females. Another thing to keep in mind is if we think about issues that are going to be directly related to COVID. So for example, can people wash their hands? Do they have good housing conditions? So it's ventilated. It allows people to practice physical distancing. So what we see is that, again, we have a pattern of inequality that creates a very large fraction of the population that are extremely vulnerable to an infection. So here I have, for example, the first map is access to water. And we see that on average in Brazil, about 83.6% of the population has access to water, but this ranges from 91% in the richest region in Brazil, the Southeast, to about 57% in the northern region where the Amazon is located. This is even worse when we look at sanitation. On average, the population is about half of the population in Brazil has access to sewage, treated sewage. But again, in the northern region where the Amazon is about 10.5% of the population. And the pictures in the bottom show some contexts where the living conditions, the housing conditions are really not ideal. If you think of respiratory diseases where ventilation is important, where isolation in avoiding crowding are conditions that are important for prevention and for control. In terms of access to health resources, here what I show is one, how we also see this major divide in the population in terms of who relies only on the public health system and who has access to private. Brazil is quite unique because it has a universal public free of charge health system, and I'll talk about this in a minute. But on average, we have 75% of the Brazilian population that depends solely on this universal health system that we call SUS. But again, if we go to the richer regions in Brazil, people have access to private insurance as well. When we look at the distribution of hospital beds and ICU beds, what we see is that there are several areas in the country that are below the minimum recommended number of ICU beds based on the population they have. And that's the map on the top right, where all the black areas are areas that are that have no ICU bed, in the gray areas that are below the minimum required based on the population. Again, if we think about the demand for ICU beds that COVID had and continues to have, we can see, how vulnerable some areas and therefore some people would be in the face of the pandemic. And then another thing, the last one I'll mention regarding this context of inequalities is one of the comorbidities that is really important associated with high mortality, which is the issue of overweight and obesity. Those numbers have been recently released by the Census Bureau in Brazil. And what they show is that obesity and overweight continues to increase in the country. Brazil now has 60.3% of the population who are overweight and 25.9% who are obese. This has an age pattern, so it's mostly the, as you go to the elderly population, you see more obesity and more overweight. But you also have a very large percentage of even adolescents that are overweight. Again, this is a risk factor for COVID. And another thing to keep in mind is that both overweight and obesity disproportionately affect the poor, the most vulnerable. So what you can see is you have layers and layers of vulnerability to certain fractions of the population. Now, the third thing I want to mention regarding context is we have an extremely polarized society. Again, that's not just in Brazil, that's in other countries as well. But the challenge here is that simple measures, simple decisions, they become political decisions instead of being decisions in public health. So the polarization creates a major barrier for implementation and adherence to policies to control the pandemic. All right, so whenever you have challenges, you have opportunities. And what I wanted to do now is to show you how Brazil had key opportunities that could have made Brazil an example on how to respond to the pandemic. Brazil could have taught the world how to respond to a pandemic using the resources you have and taking into account all the inequalities that you have in the population, taking into account the vulnerable people in the population. Okay, so the first thing is that Brazil had time to plan. And while we were seeing what was happening in Italy, what had happened in China, so Brazil knew this was going to come. It was not a matter if it was going to come, it was a matter of when it was going to come. It was clear that there was going to be a demand for protective equipment. There was going to be a demand for hospital beds. There was going to be a demand for ventilators. This was clear. And this was very different than when Zika hit Brazil, that Brazil was the first to see the consequences to pregnant women, to the fetus, to the babies. This was all new. So COVID was a different picture. Brazil could take a deep breath, plan, and be prepared when the virus would arrive. The second thing is Brazil is also unique because it's one of the few countries that has a universal health system, completely free of charge. In fact, Brazil is one of the few countries that has written in the constitution that health is a right to the population and is a duty of the state. It's right there in the constitution. Now, Brazil has also the largest community-based primary care program in the world. It's called Family Health Strategy. So basically, the family health strategy has teams of professionals, nurses. There is also a doctor, and they actually go to the houses. They visit the communities. The health agents, they live in the communities that they serve. So they actually know where the elderly are. They know where people with comorbidities are because it is their role to follow up and monitor those comorbidities in the population to provide care. They know where are the houses that have too many people living in there, that don't have access to water. So those agents could have been a key player in the local response, and above all, a key player in providing a response that actually takes a very special account for the local inequalities, for all those vulnerabilities that I mentioned. It's impossible to imagine that Brazil would simply say, let's start a lockdown like was done in Europe, and this is going to fix the problem. A huge fraction of the Brazilian population cannot possibly be in lockdown. You can't work remotely. It, you don't have, you need the income. So you have an informal job, you have to go out anyway, and many other things. I'll go back to this in a minute. So if Brazil could have used what they had in terms of the structure of the health system without inventing anything, and basically equip the health system and provide resources for the health system. The problem is, since the recession and since austerity measures were implemented in 2016, the health system was underfunded even before COVID arrived, okay? But the opportunity was there. The third thing is Brazil has scientific institutions and researchers that are absolutely first class. And despite the fact that the current government is not providing a lot of resources for public universities and sometimes attack public universities, they are producing first rate work. They are advancing the knowledge. I bring here one example that when COVID arrived, there was a team of researchers that did the entire genetic sequence of the virus in less than 48 hours. Okay, this was done in a public university. We have collaborations that is started, and this involves centers, involve universities, involve independent institutes, and it brings together physicists, mathematicians, statisticians, epidemiologists, demographers, sociologists, urban planners. I mean, you name it. It's beautiful to see how those groups got together in order to take the data, crack the data, and try to provide clear, useful information both to the population and also in trying to inform health secretariats in the municipalities or states. Now, I really stress the point of providing clear information to the population because that's an important service considering how polarized society really is. So we need those groups to be able to digest the complicated science of vaccines, of immunity, you name it, and bring this to the population. And the fourth thing in terms of opportunities is, and I always think we have to go back to history because a lot of the problems or a lot of the opportunities we have now have their roots in history. And Brazil has a beautiful history of response to public health emergencies. And I want to bring only two here. One really historical, really old, the other one a little bit more recent. So back in the early 1900s, Brazil was already trying to get rid of yellow fever. And it started, this fight started in Rio de Janeiro, that used to be the capital at the time. A lot of this work was really, really spearheaded by Oswaldo Cruz. And then in 1942, Brazil succeeded, eliminated urban yellow fever from the country. And that achievement inspired a national campaign to eliminate the vector, Aedes aegypti, who, by the way, is the same vector of dengue, Zika, chikungunya, Mayarovirus, and a few other things. So Brazil started this campaign in 42, and it succeeded. By 1958, the Pan American Health Organization declared Aedes aegypti eliminated in Brazil, but the Pan American Health Organization decided to model this campaign that was doing in Brazil and scale it to the Americas. And in fact, by the early 60s, Aedes aegypti was eliminated from the Americas, with the exception of the US, that never joined the campaign, Venezuela, and parts of Guyana. So this is a really successful story that became a regional story inspired by what was done in Brazil. Now, a more recent one is the response Brazil gave to the HIV/AIDS pandemic. This response was made possible thanks to the SUS, to the health system. It became a model of response to HIV/AIDS. And if it was not if Brazil had not given this response, Brazil could have had rates just like we were observing in Africa at the time. So extremely successful, and again, received many awards and inspired other actions in other countries as well. All right, so we had the challenge, there were the opportunities, and then the question is, so what happened? And what happened is, maybe the best word is to say a disaster. At the federal level, the importance of the virus was always minimized. Science was not really taken into account. Even worse, I mentioned before that the government is one of the players in disseminating misinformation. Brazil actually has a protocol for the use of chloroquine in mild and severe cases of COVID, despite the fact that there's absolutely no scientific evidence proving the efficacy of chloroquine for the treatment of COVID. Well, what we have is many different studies done in different places showing that it's not effective at all. Just to give you an idea, Brazil stayed more than 3 months without a minister, just with an interim minister. And the interim minister became the minister, is an army general who said publicly that he didn't even know what the SUS was, the health system was. So in making a long story short, Brazil basically failed to use the everything they had as an opportunity, everything they had that could make a difference. So it neglected to equip and to fund the health system. It didn't use the primary care embedded in the response. And the sequence of disasters are very long, but basically it didn't have a response that addressed the local inequalities. Brazil had no mass communication campaign, very different from, the history in Brazil that always use the media to have beautiful campaigns and very effective campaigns in terms of public health. There is absolutely no campaign, no information, no sensitization. So that contributes to this polarization, because then you can believe in this group of people because you voted for them, you sympathize to them, and another group will do something else because they sympathize with somebody else. So it's a chaotic scenario, and in this context where basically the federal level is absent in terms of a response, what we saw was local responses that came through different ways. One, we saw many different communities, so slums that organized themselves, and they had community groups, the industry, philanthropy, universities, basically partnering and creating ways of delivering food, delivering cleaning equipment. There were apps that were created to monitor all the numbers, the deaths, and the cases. There were apps created to monitor the elderly in communities. So if the elderly felt sick or had a fever, this would trigger some kind of message, and a team would come and, if necessary, isolate that person and isolate the family members. So and there were some municipalities that actually used the community health agents from primary care by giving them training, by giving them protective equipment, and creating the environment so that they could do their work and be the eyes of the health system in the community. So we have a collection of great local responses. But what I wanted to stress in here is that for a country the size of Brazil, it's a continental size, that has 5,570 municipalities. About 22% of those have less than 5,000 people. There's no way the response to a pandemic can be a collection of successful local experience. It has to be a coordinated action coming from the top, enabling those municipalities to be able to provide a good response. And that we haven't seen, and it's not happening yet. Just to give you an idea, what I'm showing you here is the stringency index that was proposed by Oxford University. And for Brazil, it was done together with researchers from the Getúlio Vargas Foundation and from the University of São Paulo. And basically what the index does is it takes different measures that have been recommended by the World Health Organization, like distancing, closing of schools, closing of gatherings of more than X number of people. And so the different measures, and then they basically check to what extent those measures were implemented by the different levels of the government, or if they were very relaxed. So that's the idea. The index varies from 0 to 100. The closer they are to 100, the more rigid, the more they were imposed in that particular area. The closer they were to 0, it was basically, very relaxed, close to nothing. So the left graph shows what happened in Brazil when we consider all the policies at the federal, state, and local level. That's the solid bar, the solid line. Now this line here is the dashed line, is just the federal policies. In other words, just the policies issued by the Ministry of Health or by the federal government. So you can see the huge gap in terms of stringency between the two, basically showing that most of the responses really happen at the local level. On the right, I give you examples for two different states in Brazil. The top one is Ceará state in the Northeast region, where the capital, Fortaleza, is the 5th largest city in the country. So in this particular state, what we see is that the actions, and here the solid line is the state actions, and the dashed line is the actions just in the capital, Fortaleza. So what we see is that in Ceará, the state reacted much faster, imposing very rigid policies. And then the municipality caught up. And the gray line is the same line we had on the other graph, is the federal level, so a huge gap. And then in the bottom, we see São Paulo. So it's the largest state in terms of population. It has São Paulo city, the largest city in Brazil. In this one, what we see is that the capital, so São Paulo city, had more stringent, more rigid measures, but then they became very similar to the state level ones, and still above the federal level, but less stringent than what we saw in the Northeast in Ceará. And we can do those comparisons for every single state in Brazil. It's really interesting, and it gives you a lot of insight on how the responses took place. Okay, so then in terms of outcomes, and I think it's important to see a few numbers to understand. So this is the picture I got yesterday. And what we see in here is that at some point, Latin America was having about a third of the deaths daily. So basically the graph has the deaths every day, and the different colors are the different regions. So Latin America is all in this is kind of purple color in here, in Brazil is right here. So at some point, and it was around, so around May, Latin America became the epicenter of the pandemic. And about a third of the deaths were actually coming from Brazil. More than half of the deaths were coming from Latin America. Then what we see is that at this point, India started to have a lot of deaths, but still about a third of the deaths were from Latin America. And now with the surge that is happening in Europe, we have 44% of the deaths in Europe and about 19% of the deaths in Latin America. Now, when we look at numbers, so as of yesterday, when I made the slide, we had more than 50 million cases all over the world. And the top 3 countries in cases, Brazil is the 3rd behind India, and the top 3 countries in terms of deaths, Brazil is the 2nd with more than 160,000 deaths observed. Now, what is important to see is if when we look at the epidemiological curves for cases and deaths in Brazil, Brazil had this moment in time when everybody's saying, well, Brazil reached a plateau in terms of deaths. It was more than 1,000 deaths per day. But we have to understand what the plateau really means. What the plateau means was that because the policies are not really taking care of the virus, they're not really stopping the pandemic from basically going across the entire country, what we see is that, you know, all these red cells show when you had the highest, the peak of transmission in each state. So each line here is a state. What you can see is that this plateau reflects the fact that the pandemic is just going around from one area to the other with a very high transmission. So the plateau is basically being sustained by the continued transmission and spread of the virus across the country. So it's important to keep that in mind, because if we look at the curve for the entire country, especially when you're dealing with a large country, it may really hide the spatial pattern of transmission of the virus. Now, I think it's important to tell, and I'll show you only one example, tell you one story. So this is, again, Ceará, the state I mentioned before. And what the story I'm going to describe for Ceará is also true for many other states in Brazil. So what we saw was that the wealthy areas started to have cases. So this is right in the beginning when the virus was introduced. That's the wealthiest area in the city. And that's where you have the cases in the beginning. So about 2 weeks afterwards, you still have the cases here, but you start seeing them in the periphery. And then suddenly they happen more in the periphery, and the rich area is free of cases. The story here is that it was basically the rich who would travel to Europe and then come back with the virus. They were the first ones to be infected, but they have people working for them. They have people cleaning their houses. Some of them have drivers, and they didn't release those people from work because they were sick. So the workers, the people working for the rich, population, basically got infected and brought the virus to the places where they live, to the periphery. And then those are the maps for cases. This is what happens when we look at deaths. Deaths are not happening among the rich. They're really happening in the periphery. Okay, so that is the same story if you look at many other cities, Sao Paulo, many other cities in Brazil. It starts with the rich. When it reaches the periphery, that's where it goes out uncontrolled, and that's where you have the largest number of deaths. So if you look at the statistics on COVID, mortality disproportionately affect the poor. And there's also a gap by racial categories, which I'll show in a minute. Now, it's also interesting to see those graphs here come from a study from Rafael in IPEA. And what they show is how long would it take for people to reach a health facility. So here is if people from Fortaleza wanted to take only 30 minutes taking public transportation to reach a health facility, again, it's exactly the rich um, communities that have quick access to a health facilities. And in a lot of the periphery of the city, you don't even have a chance to be able to reach in 30 minutes. And for most of the city, it would actually take about 90 minutes, an hour and a half. So it's also important to think about what are the conditions in terms of access to services when you look at the most vulnerable. So basically the story is what Dr. Tony Fauci says, the double negative disparity. So people on the one hand have a negative determinants of health, social determinants of health, as I showed in the beginning. So they have higher prevalence of comorbidities. And on the other hand, it's very unlikely that the vulnerable are going to be able to have the type of job that allows them to work remotely, to stay home. So again, as I mentioned before, it's this multiple layers of vulnerability that will make the exposure to the virus extremely high for those people. And here, this is just one fraction of Sao Paulo city, where we see basically the areas where people are coming from to take public transportation. They overlay with the areas that have the highest concentration of hospitalizations due to COVID. Indigenous people in Brazil are suffering with an extremely high burden. So in fact, here are numbers on the left are numbers for September, showing that if you take the number of cases divided by the indigenous population, this rate in Brazil is way above the rate for the non-Indigenous population. And by the way, very similar in the US. So I just updated those numbers, and as of November 9, so as of yesterday, if you take just the Indigenous, it's about 4,308 cases of COVID per 100,000 Indigenous people. In the rest of the population, it's about 2,930 per 100,000 people. And when you look at deaths, it's equally high. Now, it gets even worse if you look at the number of cases, the incidence of COVID cases in the entire Amazon region, so in the entire Amazon biome. So that covers other countries in South America. The highest incidence rates, except from one area in Peru, they're all in Brazil. So disproportionately, the indigenous people in Brazil are suffering with COVID. The same by racial categories. So Blacks and mixed, again, disproportionately are being affected. If we look at maternal mortality, Black women have almost 2 times higher chance of dying than whites due to COVID. And also among those who are admitted at the hospital, they also have a much higher mortality. So what we see is that the working conditions, the unequal access to good housing, and the unequal access to services is just part of this structural racism that is exposing the vulnerable to a much higher mortality rate. The other thing to keep in mind is the incidence of violence against women and against children has increased dramatically during COVID. This is not just in Brazil, but it is a particular case in Brazil, and that's going to have consequences for the women and for early childhood development. And then that brings me to the end, where I really would like to make a reflection of what comes next. So the first thing that I want to say is that we need to change course. We need to be able to do more than we're doing. And I really believe there is still time to save lives. And if this is not going to come from the federal government, it is going to come through local action and actually through collaborations between different municipal health secretariats. So municipalities that are doing a good response can actually help the ones that are not able or do not have resources to respond. The community health agents have to be involved. And honestly, we're going to have elections next Sunday, this week, for the local level. So mayors and the local legislators. And I hope that, people are going to be able to at least choose well at the local level. So then we would have 2 years to prepare for the presidential election that is going to come. Second thing is the whole issue of vaccines that became a political issue instead of an issue of public health. And on top of this, the anti-vax movement in Brazil is growing. So there is a survey done in August, and about 1 in 4 Brazilians are not likely to vaccinate, which is extremely high. Again, in a polarized society where unfortunately the leader of the country is hoping that one of the vaccines fail, this becomes a very delicate and complicated issue. So it shouldn't be a political issue, a geopolitical strategy. It should be a public health strategy. There is a paper that came out in the Lancet recently in September, basically showing that it doesn't matter which indicator you look at, trust in vaccines, thinking that vaccines are effective, they just got worse in Brazil. In every single indicator, it got worse. So I want to conclude by saying that it's very likely that the future scenario will be a scenario where Brazil will have even larger inequalities. So if they were large before COVID started, it's very likely that it's going to get even worse. And some of the indicators are already pointing to this. On top of that, we have increasing demand for the health system. So we have all the people that didn't have access to primary care and since COVID started, and this is going to have health consequences. We have the long-term complications of COVID that we're just learning them now, but this has cardiovascular complications, neurological complications. We don't know all of them yet. And we have the whole issue of mental health. And we have a paper that just came out yesterday showing that 2 days ago, sorry, showing that 1 in 5 COVID patients are later diagnosed with mental illness. So there is only one way that Brazil can address the outcomes of COVID, that they can address this increasing inequality and can address this future demand for the health system. And that's through its own public health system, through the SUS. So Brazil has the tools to be able to address those challenges with equity. That's the important thing. And equity is one of the principles of the SUS. If it's not with equity, then this inequality will just get bigger and bigger and bigger. So Brazil has the tools and it has to use them in order to be able to address those challenges with equity and therefore do not penalize the poor. So that's it. And we have time for questions.
Thank you, Dr. Castro, very much for that very important and informative presentation. We have received a number of questions, so I'm going to give you two to start off with. Can you compare the policies and the general discourse from the leadership in the United States and Brazil regarding COVID? And what are the checks and balances or the safeguards in Brazil to guarantee that the government reports accurate data regarding cases?
So if we compare what was done in the US and in Brazil, unfortunately, it's very similar because both leaders denied the importance of the virus. Both leaders were, basically supporting unproven medicine for treatment, making jokes of the lives being lost. So all of this is pretty much the same. In terms of data, I should say Brazil has one advantage to the US. I mean, the US, each state releases the information they want. So we have several states in the US that don't release data by race and ethnicity, for example. We just don't have the numbers. And states can do this. They can release whatever they want. In Brazil, all the systems, the information systems, they are the same across the country. And Brazil has a sheer amount of data. It's quite phenomenal, actually. So every state has to report the same. The problem here is that when COVID started, Brazil had prepared one information system to keep all the cases. But they probably didn't anticipate how many cases were there and the system didn't support. So they had to migrate to another one. And then there was a lot of confusion. And at some point, the president threatened to keep the data. And for 2 days, we didn't see any numbers. So what happened is that we have different groups that now collect the information from every single municipal health secretary. And we have different repositories with information on cases and deaths. That particular information that has every single case and death, it doesn't have a lot of details. There is one data set just for hospitalizations. And for this one, you can have everything, race, ethnicity, all the details. So there are different data and you just have to take the time to understand. We have data from cemeteries, we have data from hospitals, we have data from the health secretariats, but if you take everything as a whole, there's a lot that we can do using that information in order to understand, how the pandemic is spreading and different patterns of by age group, by race. So there's a lot that we can do that you cannot do in the US. So at least in terms of data, I think Brazil has much more in terms to inform governments and to advance knowledge than the US has.
There's a question asking you to follow up on your comments regarding the impact of the pandemic on Indigenous communities. Specifically, what challenges have they faced in implementing preventative measures that may be problematic in light of their cultural and religious practices? And how is the state monitoring and addressing the effects of the pandemic in Indigenous regions?
Yeah, that's a great question. So there is a group that is basically trying to provide support to those to the different groups, and they try to track down how COVID arrived in each one of those places. So for many of those groups, we know that it was the visit of agents of whatever from whoever monitors um, anyway, there are different ones that they could track down who was the person that came infected. In many of those places, it's connected to people clearing the forest, doing mining. So it's connected to illegal activities that there's nobody from the government there is stopping them, and that's a whole different discussion about what's happening in terms of enforcing the law and surveillance in the forest. So what's happening now is that there are a lot of vocal indigenous groups. They were able to get protective equipment, which they had none. So this is happening. They are trying to advocate for in some areas to stop the visits of people from outside, to stop transmitting the virus. In many places, people need to go out their areas to get, to bring some sometimes food, sometimes drugs, or things they may need, and then there is an attempt in trying to restrict who are the people coming to the places. But I think what is important to emphasize is that all those actions are being done by groups that came together that traditionally support the indigenous populations. It's not really coming from the federal level. It's not that the federal level recognizes that this is a really heavy burden, disproportionately heavy burden among the indigenous. Let's do something. I mean, the government never even acknowledged that this is a problem among the indigenous. So again, it's all those local initiatives that are supporting them at this moment, not from the federal level.
Thank you. There's a question regarding the role of community health workers. How can they be a resource to help with vaccine education among the population in preparation for the future?
So they would be absolutely key in doing this, because again, the community health workers, they live in the community where they work. So when they go to somebody's house to monitor their blood pressure, or to check immunization on the kids, to do prenatal care, they know those people, and people in that household recognizes that agent. So there is a trust, and this trust is absolutely crucial when you are providing care in a sort of community based. So the key issue here is that communication of the importance of the vaccine has to be built. And that can become part of their work. Those agents need to be equipped and prepared to go back to their house to house work in the context of COVID. So the majority of the municipalities didn't really receive resources. So the agents can get training, can get gloves, can get masks, enough of them that they can change every day, or multiple times a day. And so none of this is really in place. So the primary care, the network of agents have not been empowered to be able to do this. And we're going to need more agents, because some of them have comorbidities. So we cannot expect them to go back to their regular work. They can work from the health facility. And some of them may be above 60 or something, and combination of age comorbidities. So there, the potential is great, and they can be really the ones making the connection and guaranteeing that people are going to comply and are going to adhere and take the vaccine. But they have to be prepared and empowered to do this. Otherwise, they won't be able to, because they won't have the resources.
So you spoke about the campaigns of misinformation. There's a question about the resources that Brazilians can turn to in the mainstream media or the social media to protect themselves and their families? How do you see these prospects?
So, so some Brazilians turn to social media, and the thing is, depends what you watch. So there's a lot of good information in social media, but Jesus, there is a lot of conspiracy theories in the social media as well, and that's the problem. So I'll give you one example. When grocery stores and other places started to have the handheld thermometer to take your temperature, there was a conspiracy theory that that thing would give you a brain cancer, and people were really believing that. So now in some grocery stores they take you in the wrist, and I'm like, no, you really have to take in the head. There's absolutely nothing. That thermometer is not going to give you brain cancer. So social media can help, but boy, it can also create a lot of damage. That's the problem. And not everybody really knows how to filter what is good information, what is not. It's very difficult. So social media can be a great resource if people know what are the sources you can trust and you can follow. And there are many in terms of COVID that are really good, but not everybody would have access to that. And that is the challenge.
And another question just came in about individuals' behavior, their health behaviors in Brazil. Do they believe wearing masks or in the importance of keeping social distance?
Good question. So the problem of masks is that masks is a simple thing, right? Wearing a mask, the science is all there, why it's important, and it should be an issue of public health, right? But it's not. It is a political issue. So if you support X, Y, and Z, you're going to use a mask. If you don't support, you're not going to use a mask. So in that sense, it's very similar to the US. Wearing a mask in the US is a political issue. It's a statement. It's not a public health issue. So exactly the same in Brazil. So there are places in Brazil you go and everybody's wearing a mask. There are places that it really is scary. Nobody wearing a mask, crowding, drinking, whatever. So, but it's because of the polarization.
And what do you think will happen to the Carnaval celebrations? Do you think they'll be canceled?
Oh, they have been canceled.
Mhm.
Yeah, in Rio, which it has one of the largest, it's been canceled. Some people wanted to have in July, which I think it's completely nonsense, but it's canceled. Now, let's put it this way. Officially, it's canceled. Is nothing gonna happen during Carnival and people are gonna gather and do crazy things? That's a different story. But officially, it's canceled. There's no parades. There's nothing is gonna happen.
There were some stories, there've been some stories in the news about the expulsion of the Cuban doctors from Latin American countries or other Latin American countries, and how that might have contributed to the spread of COVID. So if you could talk a little about that story or the background there, and also the more recent stories about Bolsonaro's cessation of the vaccine experiments with the Chinese vaccines. So yeah, they've both been in the news, but if you have some more light that you could shed on that.
Sure. So the Cuban doctors, they were part of a program called More Physicians, Mais Médicos. And the idea of the program was to bring, so recruit physicians in Brazil, but also bring physicians from abroad, and the vast majority were from Cuba, in order to have a better distribution, geographical distribution of physicians. In other words, there are areas that is very hard both to attract and to keep the physicians working. And those are the remote areas in the interior of the country, areas in the Amazon. So it's very hard to recruit people there. So the idea of the More Physicians program is let's recruit those doctors. They're going to go to those areas that need the most. So there was a whole complex criteria to define the priority areas to receive those physicians. And once they are there, you can create one of those family health teams that are providing primary care to the population. Once the program ended and the Cuban physicians had to go back, what we had was that, for example, about I think it was 70% of the healthcare being provided to indigenous populations were from those physicians working under the More Physicians program. So immediately they were without care. In a lot of the places, the most remote areas that really relied on those physicians that were part of the program, also suddenly came from having primary care to not having primary care. So it created a rupture in the care that was being provided. Now that's one aspect. But this happened way before COVID. It happens more than a year before. But what that means is that by the time COVID arrived, the whole distribution of physicians was worse than before, and the financing of the health system was underfinanced. The vaccine is just a crazy story. So about I believe 2 weeks ago, the minister. So there are two vaccines. Let's say the two leading ones, the Oxford and the Chinese vaccine. The Minister of Health signed an agreement with the Oxford vaccine, and Fiocruz, which is an institution in Rio, is the one pairing with them. And the idea is, the production can start even before we have the results. So by the time we have something, it can be launched. The governor of São Paulo signed an agreement with the Chinese vaccine, and Butantan Institute, that is in São Paulo, is the one partnering with them to produce the vaccine locally. Now, what is the problem with this? The governor of São Paulo clearly wants to run for president, and therefore is going to be competing with the current president in the next elections. So about 2 weeks ago, the Minister of Health announced that they were going to invest X million of reais, I don't remember, with doses of the Chinese vaccine. Bolsonaro comes and say, no, we're not going to spend this money because we're not buying the vaccine from China, which he calls the vaccine from, and he says the name of the governor, from China. So then the minister had to come and say that they're not going to buy it, which was ridiculous because basically the president came and, something that the minister had just said he was going to do, he had to say, okay, second thought, I'm not going to do. And then yesterday, one person died, one person that is in the trial. And everything is stopped, which is normal. That's usually how it happens. And this is from the Chinese vaccine. And then they found the person died of suicide, and there was no link, and then the trial will come back. So Bolsonaro basically came and I mean, he was almost like happy that the trial stopped because that's the Chinese vaccine. And when he was questioned, again, he said something like, you just have to get used. Everybody's going to die. And then he points to somebody in the audience, you're going to die. Everybody's going to die. We have to stop being a country of, I don't even know how to translate in English what he said. It was just bad. So basically what we have is a president cheering, happy that we had a setback in one of the trials because that's not the vaccine he wants. So it cannot be more political and honestly stupid than that. But that's the scenario we have.
Well, we've reached the end of our program, but I wanted to thank Dr. Castro one more time for this very enlightening talk and for the audience for joining us this afternoon. And thanks once more.
Thank you. Bye.